Good afternoon, everybody, and thank you, Team Pediatrics, Dr. Veena ma'am and Dr. Frederick, for having me here to share a few insights on this extremely important pathology which affect the tiniest of the tiny, that is retinopathy of prematurity. I shall be throwing some light on the screening and management strategies. So, as we know, ROP was initially described in 1941 on Valentine's Day in Boston, and it went on to be called retrolental fibroplasia by Terry because he thought it was a persistence of the fetal vasculature. It was in 1951 that Heath noted it to be retinopathy of prematurity, and in the same year, Campbell individually, in a different setting, noted that this was related to oxygen supplementation of newborn babies in the nursery. In 1984, the international classification of ROP was proposed. This was revised in 2005, which included the term pre-plus disease. And recently in 2021, the ICROP3 classification has been given. So ROP has typically been described in these three epidemics. So if you look before 1940, there was no ROP because premature babies were not surviving at that point of time. With improvement in care, especially with oxygen supplementation, the baby started surviving. And as the baby started surviving, you had this increase or this first epidemic of ROP. Because at this time, the details about oxygen supplementation were not known. By the time in mid 50s to 60s, it was recognized that oxygen supplementation needs to be monitored and given in a systematic manner, and oxygen was restricted, leading to a drop in the incidence of the occurrence of ROP. This was also accompanied by a slight drop in the survival of preterm babies. With the modern era, with better ventilators, better medications, the use of surfactant, there is an increase in the number of preterm baby survival. There is also an increase in the number of preterm babies being born, especially with assisted fertility techniques. So this is now being called as the second epidemic of ROP. In developing countries like India, where we have a discrepancy in our healthcare systems, where on one hand you may have ICUs which are very good, NICUs which are very good, whereas NICUs which aren't so particular in the way they manage, we see babies which are a combination of both of the kind which was seen in the first epidemic versus the second epidemic. And that's why this is now known as the third epidemic of ROP. So Western literature reports incidence from 21 to 65%, is almost similar in Indian literature. So I would like to throw a little light on the normal vascular development because this helps us understand why and how we should screen. So normal vascular development in the retina starts intrauterine gestational age of around 14 to 16 weeks. It reaches the nasal ora by 8 months and temporal ora at term, that is 40 weeks. The first stage is what is called as vasculogenesis, which lasts from the 14 to 21 weeks of gestation. And this is independent of VEGF. Whereas by this time, by 21 weeks, the retina starts developing and differentiating. The neurons start forming. These require a higher oxygen demand and they produce VEGF. And this drives the later phase of vascular development, which is called as angiogenesis. And in response to this need for oxygen and metabolites, the new blood vessels start growing, they start developing, and this leads to a physiological downregulation of VEGF. This is all normal vascular development physiologically that is happening in intrauterine life. Now, what is happening is in the normal intrauterine life, there is a hypoxic condition and there is a normal level of VEGF being produced and the vessels are growing. And lo and behold, suddenly there's a premature birth of the baby. At this point, the baby is out and you are giving oxygen supplementation. Even normal outside room, the air is more hyperoxic as compared to the normal physiological hypoxia intrauterine. This increase in oxygen supply causes a down regulation or suppression of the VEGF, and this causes a reduction in the vessel growth. Now, slowly as the baby starts developing and growing up, the oxygen supplementation is now reduced. This causes a rebound increase in the VEGF production, and that is where you see the ROP developing. And that is why when the baby is born premature, even if the retina is not fully developed, it is not going to have ROP at that time. This ROP is going to develop after 3 to 4 weeks of life of the baby. So what happens in the pathogenesis of ROP now is the baby has low levels of insulin-like growth factor. This leads to poor signaling of VEGF. Then there is oxygen supplementation, abolishing the physiological hypoxia, down-regulating the VEGF. And this is suppressing the normal vascular growth that was happening in the baby's eye in the intrauterine. As the baby starts growing and developing, there is an increase in the IGF levels. There is withdrawal of oxygen, and this both put together causes increase in VEGF, and there's a destructive ROP which is happening. So another important point is magnitude of ROP. We have to remember there are 15 million live births per year, out of which 1/4 are born in India, and India has the highest number of premature births in the world. So why do we need to screen babies? So every premature baby is not born with ROP and have a potential to develop a normal retina, and a potential to have normal vision. So it is important to screen to diagnose ROP. There are medical legal implications. There have been numerous court cases over the past few years where crores have been awarded to the applicants where ROP screening was missed. And screening helps you diagnose ROP on time, helps you treat it on time, thereby preserving vision. I always say this, that there are very few instances where you have, in physiology, we learned the all or none phenomenon. In practical clinical medicine, there are very few instances. One would probably be vaccination, and the other would be ROP screening, where not doing it has a very, very dramatically different effect from what you would get if you actually did what you need to do. So whom do you need to screen? The Indian guidelines, these are the Indian guidelines. You need to screen babies with birth weight less than 1750 grams, relaxable up to 2 kgs, gestation weight 34 to 35 weeks, who are exposed to oxygen. Babies who are extreme preterm and extreme low birth weight are high risk for AROP. And sometimes babies who may be a little bigger and older but have had a lot of complications in the perinatal period may also be screened for ROP. When do you screen them? At 31 weeks of post-conceptional age or post-menstrual age, that is 3 to 4 weeks after birth. The extreme premature, extreme low birth weight babies need to be screened earlier because AROP develops earlier. AROP, or what was called AP, aggressive posterior ROP, but now it's called aggressive ROP. It happens in extremely preterm low birth weight babies, and it is known to be due to a problem in the vasculogenesis phase, because that is what is arrested. That's why it happens earlier. And like we just saw the pathogenesis, since it's not going to happen for the first 2 to 3 weeks of life, you do not need to screen the babies at that point of time. And based on the screening and your findings, the ophthalmologist will decide when is the next screening. One dictum to remember is the first screening should happen before day 30 of life for the baby. So how do you dilate? This is again something important. So the dilatation drops are half concentration of your regular commercially available tropicamide plus phenylephrine drops. I need tropicamide plus drops, half concentration, and it's very easy to do this. You take a TR substitute, you take a T plus, you mix half of this into that and half of that, and you have 2 bottles of ROP drops ready. How do you use this? 2 to 3 installations, about 5 minutes apart. The pupil will dilate in 15 to 20 minutes. If the pupils don't dilate, don't keep on adding, because in the case of plus disease, the pupil may be resistant to dilatation. And what care you have to take? You have to wipe out the drops that spill, as they can be absorbed from the delicate skin of the babies. Very important not to use atropine or normal concentration eye drops. There is a lot of concept amongst a lot of people that for dilating children, you use atropine. Atropine is used in older kids for refraction and cycloplegic refraction, and not for dilatation. I have seen sometimes babies being referred to us from outside, asked to apply atropine and go for an ROP checkup. Unfortunately, none of the babies actually did that before coming to us. This can cause severe tachycardia, hyperthermia, dehydration in the babies, can actually be fatal to babies. Anecdotally, especially for the postgraduates, a 1 atropine eye drop bottle is a lethal dose of atropine, which is regularly available in our medical shops and stores, which would use for adults in some severe conditions, can be lethal. So be very careful while using it. So how do we screen? You take an informed consent. It should be done in a well temperature controlled room to maintain the temperature of the baby, usually in the NICU itself. The baby should be fed and burped at least half an hour before the procedure, because you don't want them to have aspiration. You don't want them to regurge and have an aspiration. During screening, the baby should be making clear vocalization or crying sounds. The process of screening is extremely traumatic to the baby, and these tiny babies can go into apneic spells of breath holding. So as long as the baby is actually crying out loud and vocalizing, it means they are breathing. So be happy as long as the baby is crying their lungs out when you're screening. If the baby stops crying, you stop screening, remove your speculum, start stimulating the baby. You panic when the baby is quiet. Okay. In India, typically we do the screening under topical anesthesia. We use a special speculum called as the L-phone speculum, and we use usually a wire vectis to rotate the globe to the different areas. We don't actually depress, we just move the globes. And the oculocephalic movement, the doll's eye reflex, can help you see the different parts of the eye. So this is a special speculum called Alphone speculum. It's triangular in shape, and the two loops are irregular. So they go into each other when you close it, making it easy to put it into the very narrow palpebral fissure of these babies. You need a wire vectis or a pediatric scleral depressor. And that's how the speculum is put into the eye. You need your indirect ophthalmoscope with 20D lens, and you need your various drops. And you need an assistant to restrain the baby for you. There is a video of the screening which is being done by the doctor by indirect ophthalmoscopy. The various parts of the retina are seen. You can use a 20 or 28 diopter lens is usually preferred for ROP screening. It gives you a broader field of vision, and the typical definition of zone 1 is based on a field of view of 128 diopter lens. And of course, tele-screening is something that we also do routinely, which is using the RedCam shuttle, where a technician goes out and they take the images of the baby. This makes it easier for us to access more remote areas. Specialists don't need to travel all the way over there. The technician can go, they can image the baby. The images are relayed to us by uploading onto the internet. We sit in our base hospital, we look at those images and we give a diagnosis. And this helps us to document findings. It helps us to reach remote areas and helps in follow-up also. Babies who are deemed to require treatment or where the findings deemed to be more critical are asked to come to the base hospital. So how do you follow these up? When you have a mature retina, you go a 3-monthly to a yearly follow-up. An immature retina bi-weekly. If there is a stage 1 or 2 with no plus, a weekly follow-up. When you see plus disease, you need to, if it's type 2 ROP, treat more frequent. If it's type 1, you have to treat it within 72 hours. 72 is also the outer limit, within 24 to 48 hours. So how do you treat? Type 1 is, we treat, that is zone 1, any stage of ROP with plus, zone 1 stage 3 without plus, and zone 2 stage 2 or 3 with plus. So plus disease, the presence of plus disease is a very important criteria when you want to treat. And the opposite of this, that is zone 1 stage 1 or 2 without plus, and zone 2 stage 3 without plus, we will observe. Observe, which means you will keep a very close watch to see. At this point, they can either progress to need treatment or regress to normal vascularization. How do you treat? The initial treatment was cryo. That is, cryo was applied to the anterior avascular retina. That was the first treatment. It's usually not done now, except as an adjunct to surgery, wherein you may have a lot of exudation or detachment in the periphery and not making it amenable to laser. The main modality of treatment today are laser and anti-VEGF and surgery for advanced stages. So here are videos of laser being done for an ROP baby. The entire avascular retina anterior to the ridge is lasered in one single sitting. There is no staged laser here like we do for PRP. So what about anti-VEGF? So the anti-VEGF is a very quick treatment. Lasering a baby with ROP takes something around 35 to 40 minutes per eye and is an extremely stressful thing for the baby, for the doctor who's doing the laser, and for the anesthetist or the pediatrician who's monitoring the baby. So, and as against that, if you want anti-VEGF injection, it's a 2-minute job. You just immediately give it. The advantage other than this is that it is not destructive. Laser destroys the peripheral area. It causes scarring of that area. Anti-VEGF is not destructive. Anti-VEGF allows the vascularization to progress and to grow. There is less incidence of retinal detachments and ectopia after treatment, and lesser refractive outcome error as the children grow bigger. What are the disadvantages of using anti-VEGF? Usually, ROP laser is a one-shot treatment. You have the stage, you do the laser. Most of the times it regresses. Very rarely you may need to repeat it. But anti-VEGF needs a prolonged follow-up until the retina has become mature. There can be late recurrences. So if it is not addressed then, if the parents think, okay, now it's done, they're calling me again and again, just giving me dates, and don't come, and there's a late recurrence. Late recurrence can be as late as 25 to 30 weeks from when you have injected the baby. That is 25 weeks is like 6 months later from when you are injecting the baby. So that is important. And there is concerns about whether there is systemic absorption of the anti-VEGF, and that is going to hamper development of the lung and neural tissue. But this has not been proved in literature so far. So how do we use? We use bevacizumab. We use this for babies with AROP or very posterior staged ROP, that is within zone 1 or zone 2 posterior. We inject it within 24 hours of diagnosis, usually immediately on the same day. Half the adult dose, that is 0.025 or practically 0.03 ml, 1 to 1.5 millimeters from limbus. And we follow up the babies, and we have noted that there are 3 possible outcomes. One is that the retina progresses to become completely mature. That, as I just mentioned, if we have a baby who was born around 28 to 30 weeks, we have screened the baby at 33 to 34, noted some changes at around 35, 36 weeks post-menstrual age if we are injecting the baby. From that point till the baby is 60 weeks, it can take for it to become mature. That's a very long follow. Some of them can have progression of vascularization to a certain extent and then develop a recurrence or a reactivation. That's when you need laser. And some babies fail to mature. So this injection is one of the rare instances where we do bilateral injections at the same time on the same sitting, but like 2 separate procedures. So a separate drape, a separate speculum, separate injection, separate gloves is used for one eye and then for the other eye. But this is where we inject 2 eyes simultaneously, only case. So when we look at our data, when we have, and this is published, we saw that 53% of our babies matured and vascularized completely. 27 babies had a minimal peripheral avascular retina remaining. So these can also be considered to have been completely treated. Only 20% of babies required laser for recurrence. So we recommend there is no need for simultaneous anti-VEGF and laser treatment. And a delaying laser can give you much peripheral laser and much lesser laser required. So why do we do this prophylactic laser? Is when the babies reach 55 to 60 weeks post-menstrual age, they are now big, they are wriggly, and you cannot hold, restrain, or examine them in the OPD anymore. And leaving behind this peripheral avascular retina, we are not sure how it is going to behave in the periphery, whether it can have very, very late recurrences of activation, whether it can cause thinning, whether it can cause holes to forms. This is not known by anybody world over. So we prefer at this particular point of time to do an EUA. Along with that, we check the IOP, we check the refraction, we do all the other necessity, and whatever peripheral avascular retina is remaining, we do a laser. This is extremely minimal laser. So if you are treating a zone 2 anterior ROP, which is where most of the times now we prefer laser, anything posterior to that, we prefer injections. And if you had to treat that, you would require around 3,000 to 4,000 shots of laser to treat the avascular retina. These babies hardly require 100 or 200 shots of laser. So it's like very minimal. For advanced stages, you need to do surgery. So this surgery is again are usually done through the pars plicata and not the pars plana because that has not formed in these babies. When you are doing the surgery for ROP, the principles are a little different. Only you want to relieve the traction. So unlike all our other retinal surgeries where we do PVD induction, we complete the whole hyaloid removal, base resection, none of that is done here. There are those fibrous membranes which are connecting the retina and pulling on it. Only those are trimmed. Only the traction is relieved. And then slowly the retina is allowed to settle back or fall back in place on its own. There are a few examples of a pre-plus and a plus disease. These are all from our own imaging. This is a baby with AROP. Here you can see there's a zone 2 anterior stage 1, but there is no plus disease. Here is another stage 2 with no plus. Stage 2 organ over here, but there's no plus. And this is a stage 3 with plus disease, a very thick ridge. This is pre-laser and this is after the laser has been done. And this is what a mature retina would look like. So long-term sequelae, you can have retinal detachments occurring, especially when there's residual fibrous tissue, which can be tractional, rhegmatogenous, or rarely exudative. You can have, when stage 3 has involuted and left back some amount of traction, some amount of scarring, you can have retinoschisis happening. There can be macular drag, macular ectopia, and the peripheral avascular retina can develop thinning lattice-like lesions, and these can lead to retinal detachment. The macula in these babies tends to have a smaller foveal avascular zone. There's an absence of the foveal depression, and this depends basically on how bad the ROP was to begin with. Retinal vasculature can persist to be abnormal, tortuous, straightening of vessels. Advanced stages, when stage 3 either is treated too late or not treated, you can have falciform folds, macular and disc ectopia, drag happening. And they are also prone to develop secondary angle closure glaucoma, especially babies with significant sequelae. So that's something that needs to be also monitored throughout their life. Refractive errors is the main concern, and all premature babies need to be screened for a refractive error, even whether they developed ROP or not, because the incidence is higher in them. The incidence is significantly higher in those who receive laser. They also develop more higher, quantitatively more higher myopia. They are more prone to develop squint, and they can develop retinal detachment at any time in their life, not related to their ROP, cataract, and glaucoma. So we need to reduce incidence of ROP. How do we do it? By using blended oxygen, using age-appropriate oxygen saturations in the NICUs, addressing anemia, sepsis, and screening on time. So what do we expect a pediatrician or an obstetrician to do is to ensure that they refer the babies for screening and ensure one screening before day 30 of life, because a screening in time can save sight. Thank you.